Hello everyone, bonjour à toutes et à tous. My name is Florence Wierzyński. I'm the president of the Royal Institute of Mental Health Research affiliated with the University of Ottawa and the vice president research of the Royal. It is my privilege today to introduce a seminal research project for the Royal. A couple of years ago, Cynthia Clark, who at the time was the chair of the Family Advisory Council, connected with me with an idea about creating a research proposal to support the development of a framework for meaningful engagement of caregivers in mental health and addictions. Well, this idea was going to be an agent of change. Fast forward 2 years, Cynthia is leading an interprofessional team composed of researchers, clinicians, healthcare leaders, caregivers, family members, which co designed the framework and is now transferring the knowledge gained. Remarkably, the Canadian Institutes of Health Research, CHR, which is the federal agency which funds health research in Canada, supported this project, awarding a $100,000 grant, which was supplemented by the Royals Foundation and supported by the Royals MHR. Cynthia and Alexis are going to tell you more about the project itself in a few minutes. I'll just add that today, building on this great work and supporting the Royals' new strategy on co-creating access, hope, and new possibilities, we are now developing an institutional framework for client and family-oriented research, which will support the engagement of clients and family at all stages of clinical research, from conception to translation. Our working group is co-chaired by clients and families, and of course, Cynthia Clark is a leader in this critical initiative. The overarching rationale, as we know, is that client and family-centered care involved lived expertise and lived experience, and that client and family are active actors in care decisions and in the research that informs such decisions. As part of our vision and strategy, we want to create an environment where research is conducted with and by clients and not to and for clients and families. In this environment, we aim for true partnerships in the whole research process. So thank you very much to the organizers for the opportunity to share these thoughts. Congratulations to Cynthia and to the whole team. I very much look forward to continuing this work together. Cynthia, over to you.
Thank you, Florence, for all the work that you have done with us at the Royal and for all of the wonderful work that you are doing now and in the future to support family caregivers and clients in this kind of research partnership. I'd like to start today by talking a little bit about why we should do this research. The time is right. The stars have aligned. We've come a long way from the root concept of nothing for us without us. It's grown over the years into a broad acceptance that the voices of families do matter. Recently, organizations are adopting a governance model which includes patients and their family members as collaborative partners in all aspects of healthcare delivery. This welcome change has sparked an increased demand for volunteer caregiver advisors. In response to this need, significant material about the topic of caregiver engagements has been produced by places like Health Quality Ontario, the Ontario Centre of Excellence for Child and Youth Mental Health, and the Change Foundation and others, all great works. But still, there is a lack of quantifiable and comparable data on the topic of meaningful caregiver advisor collaboration, specifically in the area of mental health and substance use disorders. So, what are we investigating? From my own experience as a longtime family advisor to a variety of healthcare organizations, I have learned that in spite of good intentions, the engagement between advisors and staff members is not always meaningful and or productive. As the past chair of the Ontario Family Caregiver Advisory Network, I've heard many accounts from family advisory members that their struggles to achieve a balanced partnership within their affiliated healthcare organizations gets in the way of some of their good work. So we felt that answering a couple of questions would lead us to a better understanding of how to enhance these relationships. First, what elements need to be in place to ensure meaningful engagement between caregiver advisors and service providers? And how do we meet the recent increased requirement for caregiver advisors in the area of this service provision? So we do this by following SPORE. This strategy for patient caregiver oriented research has helped us in our journey to discover this really needed information to help us go forward. So as Florence mentioned, the Canadian Institute for Health Research has funded our project. And this framework, within a nutshell, is a strategy that engages patients, researchers, and other stakeholders as partners in research. It also answers the questions that are important to patients, and it aims to improve health and healthcare systems. And note here that patients does include families in this definition. So, with the support of key members of the Royal, our research proposal not only met the criteria for patient-oriented research, but I would say it took it to another level. For example, built into the funding proposal was dedicated resources for the development and dissemination of knowledge products. This additional step of immediately translating their research results into useful products, I think, can be viewed as a motivating factor for participatory research and the incentive for supporting research partnerships. The nominated principal investigator is a caregiver, which is me, which I believe is quite unusual. And the co-designed collaborative models were applied to all aspects of this research, including the project planning, the survey design, research team engagement, expert working group consultations, and of course, the development of our educational products. So I just want to talk a little bit about what I think our group is so unique. So as you can see here, and as we have a number of what I would say different issues to deal with from other caregivers. And I wanted to also share with you the opinion poll that came in 2019 from the Ontario Caregiver Organization. It indicates that 46% of caregivers who support someone with mental health challenges are not handling the situation well. 57% say they're not coping well emotionally, and 47% said they're not coping well physically. A strong majority agree that they often feel anxious, worried, overwhelmed, frustrated, helpless, and trapped, and they're not getting very good sleep. So I like this figure here because when you look at it, you can see in the boxes that there are a lot of issues that face our caregivers, and behind those titles, you might see some other things going on, like the legal issues that we get into and having to maybe call the police. It is very, very taxing and very difficult for some of our caregivers. So these specific challenges facing the families who support someone with serious mental illness and substance use disorder are sometimes ignored and at least not highlighted in the discussions. Simply put, many times we couldn't see ourselves in the ongoing public discussions by governments and agencies and organizations that are supposed to be focused on caregiver issues. It is within this group that we will find the caregivers who are volunteering their time to support others and to work very hard with service providers to improve care. And they're also champions of change. So that kind of is the group that we will be drawing from our caregivers. So our principles, our key principles. This guided us through our research. We're focusing on meaningful engagement for caregivers, advisors, and staff. Recognition of the unique lived experience of our family caregivers in mental health and substance use service environment, which I just talked about. Family caregiver advisor engagement throughout the course of the research. There was a lot of participation from them, and I have to say from the service providers as well. And we did apply a gender-based lens, which Alexis will talk to you a little bit about in a few minutes. So our project overview. We had 3 phases. The first one was a discovery phase, but we collected the perspectives of caregivers and service providers with and without experience in the collaboration. And we wanted to get a very broad perspective there. We thought that was really important. We always plan for a collaborative event where we're going to discuss the data that we collected with expert caregiver advisors and their related service providers to establish the best practices and information delivery options. Also, where we are now, we wanted to create these knowledge products and these tools that are going to help everyone. And we hope to aim them at community organizations and health institutions. So the study, there were a couple of study alterations, and of course, as everyone is experiencing, we're in a time of a pandemic. So what happened was we had to make some changes to our project timeline. And we had a hiring freeze, which delayed the start date from March to June. And also, we were very lucky that CIHR extended our contract and funded us for the extra 2 months. So that was the bad news and the good news there. Also, other COVID-19 challenges. A lot of what we had planned to do was going to be in person, in a very collaborative model of work groups, brainstorming groups, and a symposium where people could come together. Well, of course, we had to change that, and all of our connections are now gone online, and our work group had to be done via Zoom. But as I understand it from people who participated, they thought it went really well. So we're very happy with that. The last thing is we had limited access to the Royal. So the usual paperwork and must do sign in person documents had to be done differently. And another employee accepted that role on our behalf. So we're very thankful for all the different accommodations that were made for our research project. So these are our phases, and I think it's important to go over them because I am hoping that some of the people that are here today will really find this interesting because they will want to take up this kind of research and they'll have a better idea of how it might go, because I, as a novice, didn't. So I want to share this with you. And actually, Florence did say a few words about the 0 phase. when I had this idea, I saw the call for the research proposals for us and I just had a discussion with her, and I said, this I think is really important and it's timely, and we should hopefully be able to work together to make this happen. And she was more than accommodating and had some wonderful ideas herself. And really this possibility became a reality when the Royal readily supported this topic for investigation. And I was so encouraged by all the caregiver advisors and researchers and service providers and community partners that agreed to be named on this proposal and were very enthusiastic about going forward with it. So after rolling up her sleeves and writing this proposal, it was submitted in September 2019. And in November, we received the good news that we had received the funding. And I was ecstatic and kind of shocked, but it was wonderful news. And so we were ready to go forward. So we first began our, so where am I? Okay, March. Okay, so we first began, we were going to have our launch in March, and so we started in June. We had our two teams, one with caregiver advisors and the other with service providers. We worked from service templates that were already existing products that we found when we did our environmental scan. Both teams created surveys for their specific cohorts. After a few minutes, we had produced a few meetings, didn't take a few minutes. We actually produced our surveys about the specific cohorts. This involved the involved caregiver advisors were at this point compensated for their time. During July, these surveys were reviewed by the Royals research team to ensure that we had no mechanical issues with the surveys that we had created. After this, two other teams of external caregiver advisors and external service providers examined the surveys. Their comments and corrections were adapted into the final surveys, and the external caregiver advisors once again were compensated for their valuable contribution. By the end of August, we had finalized the methodology we wanted to use to complete the Royals Ethics Board application. That's an REB. We also knew that we would have to apply for an REB amendment once we analyzed our survey results. And because we would then seek the approval for the specific discussion questions and methodologies that were going to be used in the collaborative events. Of course, we didn't know that yet, so we had to wait. September was spent mostly preparing for the survey launch, which happened on October 16th, and it is such a wonderful feeling to get the surveys out the door. We circulated these surveys through personal networks. The Royal advertised the survey with staff members and had the study available on the website in English. We advertised on EENet through their newsletter and their online forum. And we also pay for a short Facebook ad. And I'm hoping, I rather believe that some of you out there have filled in our surveys, so you're familiar with it. When the online survey closed on November 30th, we had 173 initiated online surveys collected, which exceeded our goal. Within the next 4 days, the data was analyzed for trends that were considered important for our future knowledge products. In December, our REB amendment was submitted, and that took us to the end of the year. And here we are in 2021. So in January, we worked on a research summary report and a manuscript. And a manuscript is what we're going to submit to have an article in a published magazine, or I guess it's all online now, but basically publishing our works. We also planned and prepared for phase 2 event. That took us into early February, where we hosted our virtual focus groups of experienced caregivers and service providers. And these expert participants were given information and questions ahead of time to have a look at. There were 3 focus groups that were held for 1.5 hours each via Zoom. And we also used the breakout room feature for our small discussion groups and came back to the main group to really share information in our findings. Anonymous exit survey was also collected for any last thoughts that someone might have had after they went home. And Alexis is going to go into this in more detail about our findings later on. For March, as we planned, we have released a study report, which you will be able to find on the resource section of this website. We are now in the process of developing a detailed plan for our knowledge product creation. The co-design process will continue throughout April and definitely go into May. In June, we plan to have the knowledge products reviewed by our expert teams. And by the end of July, our knowledge products will be completed. It is our hope to formally make our tools and our products available by September on some sort of platform, and we'll try to get the word out when that is done. And so now I'm going to ask Alexis to share the highlights of the research findings.
All right, thank you so much, Cynthia. Now, during this project, we knew it was important to include caregiver advisors and service providers as equal contributors in every step, as Cynthia mentioned. However, when it came to choosing a population to sample, we felt it was important to also include individuals who had never been involved, but could one day potentially become involved. As such, our final sample included 4 different target demographics. The first were past caregiver advisors. These were participants who were caregivers, so family members or close friends who assist a person living with mental illness or substance use and concurrent disorder. Not only were they caregivers, but they had to have previously been involved formally with a hospital, community organization, or government agency to inform on all levels of the operation in a variety of positions, such as a working group or a steering committee. We then had potential caregiver advisors. Now, these were participants who were caregiver advisors, but had never been involved formally as an advisor, either at hospital, community center, or government agency. We also had experienced service providers. These were staff members at an organization that provides mental health and or substance use services within Ontario, Canada. To be considered experienced, they had to have been previously worked with caregiver advisors at their organization. Similarly, to inform on all levels of the organizations, and could have been committees, councils, and so forth. Our last group were inexperienced service providers, and these were staff members at the organization that provides mental health or substance use services within Ontario, Canada, and had no experience working with caregiver advisors. By including all of these groups, we aim to understand the needs of those involved and the perspectives of those who could potentially become involved to create a thorough understanding of the current state of collaboration in mental health organizations in Ontario, Canada. But were we able to reach everybody we wanted to? Sorry. Our final sample for the survey in phase 1 included 40 past caregiver advisors, 44 potential caregiver advisors, 24 experienced service providers, and 14 inexperienced service providers. From this, we felt we certainly had reached caregivers, but had a little bit more difficulty sampling service providers. For our original project planning, there are certain groups we felt were harder to reach, such as residents of Northern Ontario, those who access community organizations, and those who had loved ones living with substance use and concurrent disorders. While there is more information about the sample in our report you can access, I can tell you now that we were largely unable to reach residents in Northern Ontario. However, we had successfully sampled individuals who accessed, advised, or worked at community organizations. We also successfully reached caregivers with loved ones living with substance use and concurrent disorders. Which brings me to the bad news. Unfortunately, we did not sample enough male participants to do a gender-based analysis. For past caregiver advisors and inexperienced service providers, only one male was surveyed in each category. Therefore, the gender-based analysis we had planned was not possible, and the guiding principle of including gender-based lens could not be included in the project moving forward. Fortunately, we did have other exciting results. From these, there are certain topics that stood out, and we've decided to present them into 3 different categories for today's presentation. First, we're going to highlight some positives of the current collaborative climate identified by the survey. Secondly, we discuss possible areas of improvement. And finally, we discuss areas of focus for phase 3 of this project, which means there are certain topics that stood out during the survey portion that we decided to investigate more thoroughly. So let's begin with the positive. When we asked past caregiver advisors and service providers about their past engagement, over 80% of participants agreed that upper management and staff supported working with caregiver advisors. Most participants also felt the organization provided timely information and updates, and that the organization provided recognition for council and committee work. From this, it seems clear that participants felt their organization did support them in collaborative efforts. When we asked past caregiver advisors specifically, they also acknowledged that nearly all of them gained an understanding of the organization's culture in clinical terms. Most of them agreed that their work resulted in real change, demonstrating their involvement had some positive outcomes beyond how the organization treated them. Another resounding positive was that everybody seemed to want the same thing: to improve the experience of caregivers and clients as an outcome from their involvement. Not only this, but many reported that they wanted the opportunity to work with clients and family and staff, which is a wonderful baseline that participants want the same things and want to work with one another. However, there are some factors that have prevented involvement from caregivers. For example, we found that nearly all potential caregiver advisors were prevented from engaging by family-related duties and interpersonal demands. Career, volunteering, and work demands also prevented or hindered engagement from both potential and past caregiver advisors. Stigma related to their loved one's condition was also reported as a hindrance by approximately one-fourth of caregivers. So, while there are some factors we can't exactly remove, we also asked them if there was something that prevented them in the past, and one of the most commonly reported limitations was a lack of awareness of available positions, which makes us ask, how do we get potential caregiver advisors aware of these positions? For our survey, we found that many past caregiver advisors were directly recruited by existing caregiver advisors or staff. Direct recruiting was also acknowledged as a strategy used by many experienced service providers. And while over half of potential caregiver advisors suggested using direct recruitment, more actually recommended using advertising on the organization's website or social media. While some experienced service providers acknowledged the organization used both these things, more efforts may be needed in these areas to potentially reach these people they're just not reaching at this moment. And which brings us to the exciting part of the project. What topics did we choose to explore further for phase 3? Before we get into those, I want to discuss how we examined topics in phase 2. Firstly, we identified experts. These were caregiver advisors or service providers who had at least 1 year of experience working on one project working with caregiver advisors in collaboration in a mental health organization. We invited them to attend 3 online focus groups. Each focus group was an hour and a half long and focused on a specific topic. These sessions included small group discussions, which were brought to the attention of the entire group after every breakout session. During the sessions, we hope to find possible solutions to the common needs highlighted by the survey. Our goal was to collect suggestions for the development of our knowledge product. During these discussions, 3 topics were highlighted. Sorry. First, we asked past caregiver advisors and experienced service providers if they felt the following topics were important to train caregiver advisors on, and if caregivers advisors had received the training, or if the organization had provided it for the service providers. Out of these topics, we felt that how to share their personal experiences was perhaps the most unique and important for our caregiver advisors. Nearly everyone felt it was important. However, less than 25% of participants felt that they had received the training. Looking over our results, we wondered how best do we approach this rather complicated training topic. We knew that a lot of material had been produced over the years of how to talk about a personal story for awareness. However, we wanted to focus on how to bring up personal experiences at a table as an advisor, so that the story can be constructively shared in a consulting environment. For these answers, we asked our experts. First, we asked what elements or qualities of personal experience make certain experiences important to share as a caregiver advisor. While we received several thorough answers, a couple stood out for discussion. Firstly, having a specific goal and sharing it came up within several of our groups. The idea was that when you have a personal experience, why you're sharing it is important, and it should be the main focus in bringing it up to the table. Additionally, the story shared should be specific to the audience and relevant to the topic at hand. The goal is constructive stories, which, from what we found, means they should be short, direct, and targeted. We then asked what approaches or practices can caregiver advisors use to constructively share personal experiences. Remember that advisory is different than advocacy was an important comment made. It identified the difference in context from sharing a personal story about your journey for improved awareness compared to the practical nature of advising. This comment has set the tone for knowledge products we wish to produce. Also, caregiver advisors need to consider the organization they are sharing with. This comment highlighted that if caregiver advisors are willing to take their time to become involved, there needs to be an understanding from the organization that is ready and able to move forward with the suggestion. Therefore, the organization needs to be accountable to the expectations of caregiver advisor consulting to them. Knowing that tokenism is one of the consistent complaints about caregiver advisor involvement, the specific topic seemed really important. For our next topic, we focused on service provider engagement skill training. Nearly all service providers felt that caregiver engagement skill training was important. Less than half of them felt their organization provided the training. When we asked if they had received the training or expected to be given it if they became involved, less than 30% of service providers felt their organization had or would give them comprehensive training. After identifying the needs for this training, we realized that engagement skill training included a variety of topics. To better understand what type of training should be involved, we asked our experts again. First, we asked them what teachable skills do service providers need to engage caregiver advisors in their organization that would benefit collaboration. While there were several suggestions given to us, we later discussed what would be practical to create for our project. Foundational organizational skills became a focus as we realized that these base organizational skills dictate the success of a meeting or a project. When we asked what methods can be used to teach these skills to service providers, keeping in mind possible resource limitations, again, we had a wonderful list of options. Of these, and for the focus of this project, co-facilitation opportunities was particularly interesting and considered a very practical way to get partnership even at the beginning of involvement. We have considered creating a co-facilitation orientation where caregiver advisors and service providers undergo the same orientation process when getting involved with a collaborative project, which would be co-facilitated and co-attended. For practical reasons, prescriptive material became a type of guiding principle for making our knowledge products. It was acknowledged in the survey that caregiver advisors do not have additional time to take unnecessary training. Therefore, training should be specific to the project and the role of the participant. This was confirmed in our virtual focus group that outlined that training should be broken up into small, specific topics that can be selected for specific need, and that is what we plan to do. For our last topic, we focused on what participants wanted out of collaboration. We found that past and potential caregivers often agreed on what considerations were important when getting involved. Of these, being given opportunities to be matched with suitable and interesting tasks was considered important by the majority. However, when we tried to answer what a suitable and interesting task was among our small team, we soon realized that this could have a variety of definitions. Similarly, we found that many experienced and inexperienced service providers considered being given opportunities to be matched with suitable and interesting tasks important. However, we also asked them if they believe their organizations provided these. Approximately one half of experienced service providers felt their organizations provided these, while only 7% of inexperienced providers agreed. But in terms of our virtual focus group, we had to once again ask, what is a suitable and interesting task? According to our experts, suitable and interesting tasks have some very specific qualities, and it seems the most important qualities were true for both caregiver advisors and service providers. Of these answers, it was made especially clear that the tasks must align with the values, interests, and skills and availability of those involved, especially for caregiver advisors. In this way, the involvement of a caregiver advisor should be personal and specific to their own skills and interests. Similarly, the project needs to be important to the service providers and their organization. Therefore, the task needs to be appealing to all parties involved. But how do we fulfill those needs? To answer that, we asked, how can organizations provide suitable and interesting tasks that match the skills or interests of the caregiver advisor or service provider? While many of these suggestions were interesting and thoroughly discussed, using an inventory for caregiver advisors and opportunities was a fairly well accepted answer that included recording and following caregiver advisors' needs and skill sets to match them appropriately to the tasks available. Some of the suggestions included a self-populating inventory where caregiver advisors would fill out an application and choose opportunities that were advised. This would ensure transparency of opportunities. Another option was the inventory was suggested to be used by service providers to identify caregivers that would fit into the project they were doing as a type of recruitment inventory. Either way, it was acknowledged that this inventory would have to be an additional cost to the organization, although it was considered very important to ensure matching was successful. And to ensure this inventory was successful, it was also recommended that a staff liaison be hired and to maintain the database and organize caregiver advisor efforts. Moving forward with our project, we plan to create products that match not only the topics of interest, but also the formats that were wanted. So when we surveyed these in terms of knowledge products, an interactive virtual workshop or online written guide were often agreed upon as ideal knowledge product formats. As such, we aim to create these products that match these descriptions and topics highlighted by our research. Now then, Cynthia, I pass on our hopes to you.
This time I decided to unmute myself right away. Okay, so thank you, Alexis. Thank you for the marvelous work you've done here, and also for keeping us on track and being flexible, because I doubt that many researchers have to take on all these other roles like the development of products, but she's kept us on task and on board and focused. So that's amazing. We're very much looking forward to developing our roadmap for our tools and all of our resources that we'll be able to hopefully connect. Some that are already out there, we want to put them in one place that people can access them. The skills training for service providers, we've talked about how to tell a story and the defining suitable, interesting tasks. Those are what we're going to be focusing on. And we hope that we can do justice to those three particular areas. But I just want to talk a little bit about my hopes for the future. And I just hope that, people will take this information that we have provided and use it to the best advantage for whatever they're trying to do. It could be, developing a Ask the Expert tool, or it could be, just using the data as a reference when they want to promote something that they want changed or ask for resources within their organization. So I'm thinking there's a lot of uses that even you can use from the data. And everyone has their dreams, and mine would be to create a central support hub for caregiver engagement that would foster like research collaborative products and partnerships like we've done here. And maybe some skills training from people who are already immersed in the topics could help others in understanding what would be the best practices for this collaborative engagement. Have a repository of caregiver advisor volunteers. There's so much work that can be done to really help meet the challenges of this collaborative partnerships between caregivers and service providers. So I hope you found our information interesting, and we are very much looking forward to your questions. And I'd like to thank everyone for coming here and today and showing their interest. Goodbye.